Okay, we'll get started, Julie, and I think we're going to stop at Human Services. We'll get through those, and then we'll take a pause and see if there's questions.
Yeah.
Okay. Please proceed. Thank you.
All right. So now we're going to continue on with LDH. Like the chairman said, this is a big agency and a big presentation, so we're going to have a few stops in the center for questions. So the total budget recommendation for fiscal year 24 that's in House Bill 1 is $20.7 billion. On the left, you can see that $14.9 billion is from federal funds, $2.9 billion from state general fund, and $1.5 from statutory dedications. On the right, you can see that $18.8 billion is budgeted for Medicaid. That's 91% of the budget, 9% for LDH agencies, and 1% for the human service districts. LDH is split up administratively into two different areas. Have the LDH agencies on the left, including the Medicaid agencies, and also to the right are the human service authorities who act independently. Here we have the 10-year historical spending. The average annual change over 10 years was right at 9%. The historical budget, we're looking at the beginning budget versus the final budget, and the shade in green is actually the actual spending. For fiscal year 22, the unspent budget authority was 7.7%. Here we're looking at prior year actuals, comparing 22 final budget to the amount spent, and we can see the unspent authority is $1.5 billion. Most of this was from federal funds. The existing operating budget in August, there were carry forwards from 22 to 23, and then also in August there's an IET budget to increase the budget authority by $200 million for funds received from GOSEP for COVID. Then in September, there was another budget amendment that totaled $1.4 billion to create the budgetary framework for the new hospital supplemental payment model. The main source of funding is federal funds, the majority being from the Medicaid program. The department also receives federal funds from community mental health service block grants, substance abuse prevention and treatment block grants for the Office of Behavioral Health. And then the WIC program, the STD and AIDS prevention program, and the Office of Public Health. The department receives $2.9 billion in state general funds and $1.5 billion from statutory dedications. The next two slides break up the various statutory dedications. The top three are all used by Medicaid and total $1.4 billion. That's the continuation of the stat debts. Here we have the funding comparison. Because LDH is so big, there's over 20 means of financing adjustments and over 60 adjustments total, and we'll go through those as we go through the state agencies. Here we're looking at the budget from the state general fund for each of the agencies, and you can see out of the $2.9 billion state general fund budget, the Medicaid vendor payments, which is Medicaid payments, is $2.2 billion. Then total funding, here we have the total funding for each of the agencies, and we'll go through each of these agencies throughout the presentation. Here we're comparing LDH to the state budget, and we see in 24, LDH is receiving 41% of the total state budget and 25% of state general funds. Expenditure recommendations, other charges is 91% of the expenses within the departments is primarily for Medicaid. Here we have the 7-year expenditure history, and at the bottom you can see the 5-year average. Expenditure comparisons, now we're looking at the expenditure comparisons from the EOB to House Bill 1, and there was a $340 million change at the end of the changes, and the majority of them were in other charges. The largest expenses and other charges is Medicaid. You'd also know that personnel costs and operating costs for the human service districts totaled $195 million, or in the other charges category. And then on the right, we have the interagency transfers. LDH transfers $209.4 million to OTS for major IT projects and $32.5 million for OTS-based services, for a total of $241.9 million transferred to OTS. Personnel information, now we can see the total positions as of January 30th. There were 776 vacancies. On the right, we have the historical On the right, we have the historical average salary. You see that LDH has historically been on trend with statewide average salary. At the bottom, we're looking at positions compared to salaries. And here we're looking at the turnover history. LDH is in yellow, the state in blue, and you can see that LDH is historically, the last couple years, the turnover has been higher than the state turnover. And then on the right is the top vacated positions. I'm going to turn it over to Blair for the Human Service Districts.
Good afternoon, Mr. Chairman, committee members. My name is Blair LeBlanc. I'm with House Fiscal, and I will be presenting this section on Human Services Authorities and Districts. On this slide, we look at the funding recommendation for the Human Service Authorities and Districts for fiscal year 24. Total budget recommended for fiscal year 24 is $224.2 million. The two largest means of finance include State General Fund at $137.5 million, or 61.3% of the overall means of finance. Interagency transfer at $64.2 million, or 28.6% of the total means of finance. And on this slide up here, you can also see the breakdown by agency, of course, across all the service authorities and districts. This slide gives you a 10-year spending history for the Human Services Authorities and Districts. In fiscal year 14, there were 4 Human Services Authorities/districts added. In fiscal year 20 and 21, a portion of State General Fund was replaced with coronavirus relief funds. Overall budget growth over the 10-year period, as you can see to the right, is 6.4%. Sources of funding for the Human Service Authorities and Districts include, you have State General Fund of about $137.5 million, interagency transfers at $64.2 million, self-generated revenues at $19.1 million, and federal funds at $3.5 million. This slide shows a comparison of fiscal year 22 actual expenditures, fiscal year 23 existing operating budget, and fiscal year 24 recommended budget. There is a $3.9 million decrease from fiscal year 23 to 24, primarily due to State General Fund, a $5.9 million decrease due to removal of the 27th pay period and other various standard statewide adjustments, and a $3 million reduction from the Acadiana Area Human Service District for a special legislative project. That legislative project was for a 70-bed substance abuse treatment facility in Lafayette. Federal funds has a $2 million increase to accept a federal grant for both the Metropolitan and the Acadiana Area Human Service Districts, $1 million each. And at this point, we'll see if this, we have staff here from LDH answer any questions on the Human Service Districts and Authorities. Or
Okay, thank you, Blair. Members, are there any questions regarding Human Service Districts? Hang on, Representative Cruz for a question.
Hey, Mr. Chairman, I was wondering how the questioning is going to go on this. Did you want them to present all of them first and then go back, or do them individually? You're going to stop each time?
No, we're not going to stop after each one. We're going to stop at a section that pretty much is pretty consistent in terms of where we are, where the agency responsibilities
Well,
are.
let me just ask one question here then regarding that 27th pay period. Are you saying we budgeted for the 27th and then we didn't have one, so we took it out?
well, it's not needed for the upcoming fiscal year, so it's not in the next. It's
Right,
not
so most years we don't have a 27th
That's
pay
correct.
period, but it looks like we planned for it and then we remove it?
No, well, yeah, they just plan for it. It creeps up about once every 8 or 9 years, I believe.
Okay, you're just saying because last year had one,
Correct.
when we're comparing, we're removing it for this one?
That's correct, sir.
Okay,
Yes.
thank you.
Thank you, Representative Cruz. There are no more questions. Please proceed, Blair.
I will return.
Or Julie?
Yeah.
Yes.
Okay, the first agency up is the Office of Secretary. This agency houses the executive management operations of the department and houses the health standards section. The fiscal year 24 funding recommendation for the Office of Secretary is $105.9 million. At the bottom, you can see that salaries and related benefits are 54% of expenses, and other charges are 23% of expenses. Historical spending, the average annual spending change over the last 10 years has been 1%. The funding comparison that you'll see that in this agency, the state general fund is state general fund driven, and all of the adjustments from fiscal year 23 to 24 are in the state general fund. The changes are driven by employee pay raises, related benefits, increase in the mobile cancer screening, and transferring positions from the Office of Public Health and the Medical Vendor Administration. Here we have the 7-year expenditure history, and at the bottom it has the 5-year average. The expenditure comparison, we're comparing the changes from fiscal year 23 to fiscal year 24. At the bottom, you can see the other charges and the payments to the state agencies, which are also part of other charges. Our next agency is the Office of Aging and Adult Services. This agency aims to develop and provide enhanced services that offer meaningful choices for people in need of long-term care. The fiscal year 24 funding recommendation is $65 million, and it primarily comes from the state general fund and interagency transfers. At the bottom, you can see about 69% of expenses go towards salaries and related benefits, and the other charges make up about 18% of the expenditures. Here we have the historical spending change, and the 10-year average is 0.03%. Okay, the change from fiscal year 23 to 24 is 1.5 million. State general funds is increasing by 416,000, primarily driven by a means of financing swap for the Traumatic Head and Spinal Cord Injury Trust Fund based on projected collections in fiscal year 24, and then 1.7 million increase in IAT, primarily driven by statewide adjustments to realign salaries to the current rate and due to increases in related benefits. Then the decrease in statutory dedications is due to the projected collections from the Traumatic Head and Spinal Cord Trust Fund. Here we have the 7-year spending history, and then the bottom, the 5-year average. Looking at 23 expenses compared to 24, personnel services is increasing by 2.8 million. Other charges is decreasing by 1.2 million, and acquisitions and repairs is decreasing by 170,000. Next up, we have the Office of Public Health, the second largest agency in LDH. The mission of this office is to protect and promote the health and welfare of all individuals and communities in Louisiana. The funding recommendation for fiscal year 24 is $855 million, and 74% of the funding is federal. At the bottom, you can see that other charges makes up about 69% of expenses, and salaries and related benefits make up about 16% of the expenditures. The historical spending, the average annual spending over 10 years is 20.9%. Funding comparison, there's a $282 million reduction in funding from fiscal year 23 to 24. $200 million is from is an IAT that was received in 23 from GOSEP that they're not going to receive again. And then federal funds are decreasing by $86.1 million due to COVID grants that expired. Here we have the current budget, or the budget as of 12/1, the EOB budget, and what was different from what was appropriated was that $200 million from GOSEP. Here we have the 7-year expenditure comparison, and the bottom is the 5-year average. Now we're looking at the change in expenses from fiscal year 22 to the actual fiscal year 22 actuals to the fiscal year 23 EOB in 24. The majority of the decrease is due to federal grants related to COVID. At the bottom, we have the other charges and IATs. And Blair's going to go through Office of Behavioral Health.
Okay. On this slide, excuse me, we'll take a look at the fiscal year 24 funding recommendation for the Office of Behavioral Health. The total funding recommended is $377.6 million. Broken down by means of finance, show that the two largest sources of funding include State General Fund at $139.2 million, or 36.9% of financing. Interagency transfer at $140.6 million, or 37.2% of the means of finance. In terms of expenditure categories, two largest categories include salaries at $98.1 million, or 26%. Other charges, $85.4 million, or 22.6%. This slide gives you the 10-year historical spending average for the Office of Behavioral Health. As you can see, the total budget has increased by 1.9% over the 10-year time period. This slide gives you a comparison between the fiscal year 22 actual expenditures, fiscal year 23 existing operating budget, and the fiscal year 24 recommended budget. There's a $24 million increase, primarily due to State General Fund. There's an $8.9 million increase driven by the following: a $5.6 million increase for a contract at the Eastern Louisiana Mental Health System, and a $2.1 million increase in existing contract for 2 psychiatrists and 1 psychologist. Interagency transfers, $15.9 million increase, primarily driven by increases in operating services for contract nurses at the Central Louisiana State Hospital and Eastern Louisiana Mental Health System. This slide gives you a breakdown by expenditure category over a 5-year average. As you can see, the two largest expenditure categories are personnel services at $135.2 million, or 53.6%, and other charges and interagency transfers of $86.8 million, or 34.4%. On this slide, you can see we have an expenditure comparison between the fiscal year 22 actuals, fiscal year 23 existing operating budget, and fiscal year 24 Hospital 1 recommended budget by expenditure category. Some of the major other charge expenditures include $27 million to addiction enhancements and accountability, $18 million for inpatient psychiatric beds. Among the major payments to other state agencies, you have grants to the human service districts and authorities, which make up the biggest portion at $47.5 million. Taking a closer look at significant expenditure changes compared to the fiscal year 23 existing operating budget. Excuse me. In personnel services, $1.9 million net increase due primarily to $4.8 million decrease associated with the removal of the 27th pay period, and a $6.8 million increase for related benefits-based adjustments. Acquisition and major repairs, $1.4 million decrease due to non-reoccurring repairs and replacement of equipment at Eastern Louisiana Mental Health System and the Central Louisiana State Hospital. And at this time, I'll turn it over to the staff at LDH for any questions y'all may have on the agencies presented so far.
Okay,
The offices
thank
so
you.
far.
Thank you, Blair. Representative Cruz for a question.
Blair, I had a question real quick on page 46. Office of Behavioral Health had historical spending, and you said the average annual spending change over 10 years is 1.9%.
The total, yes.
How does that work? I went back 10 years from your endpoint to 230.5, did 10 years and 1.9%, came up with 279 million. Where are you starting that graph from, I guess, that 1.9%?
It would be the fiscal year 13 to the fiscal year 22.
13 to 22.
Yeah.
Okay,
The last 2 years of the budgeted years.
gotcha. Thank you.
It's also the average change over 10 years. It's not this from point A to point B.
Okay.
Okay, there are no additional questions. We'll move on.
Next up is the Office for Citizens with Developmental Disabilities. They oversee several waivers, the Early Steps program that handle legacy costs for the privatized developmental disabilities facilities. The agency also houses two facilities, the Pinecrest Support and Service Center, and then the Central Louisiana Support and Service Center. The proposed fiscal year '24 budget is $205.4 million. 73% of that is from interagency transfers, and 20% of that is from state general fund. At the bottom, you can see that expenditures, salaries, and related benefits are 66% of the total budget, and other charges are 12%. Here, the historical spending, the average annual spending change over 10 years is 1.1%. The funding comparison is comparing the fiscal year '23 EOB budget to House Bill 1. There's a $73,000 decrease. $1.4 million in IATs due to the 27th pay period being non-recurring acquisitions. There's $419,000 increase in statutory dedications. That's due to the increase in claims for early step providers, and a $795,000 increase in federal funds for the use of the ARPA funds to support special education-related services as well as early intervention services for infants and toddlers. This is the 7-year expenditure history, and at the bottom is the 5-year average. Looking at expenditure comparisons from fiscal year '23 to '24, the net increase is $73,000 again. There's a $3.9 million increase in personnel service, $4.5 million reduction in acquisitions that's related to equipment purchased in fiscal year '23 at the Pinecrest Support and the Central Louisiana Support Services Centers. Now we have the Louisiana Emergency Response Network Board. LEARN is responsible for developing and maintaining a statewide system of care and coordination for patients suddenly stricken by serious traumatic injury or time-sensitive illnesses. This agency, along with the developmental disability, operates autonomously from LDH. The funding recommendation from fiscal year '24 is $2.5 million, mainly from state general funds, and about 62% of the expenditures are for salaries and related benefits. The average annual spending change over 10 years is a 0.1% increase. The increase in fiscal year '21 and then the following decrease was funding received for the Orleans Parish Communications Center added in 2020 in the second extraordinary session. The net increase in funding from fiscal year '23 to fiscal year '24 is $150,000. There's a means of financing swap between state general funds and IAT and fees and self-generated revenue. Is for a decrease in the funding from the Living Well Foundation and the Traumatic Care Resuscitation. Those funds are being replaced with state general funds. Next is the Developmental Disabilities Council. The council was founded in 1971 and contracts with agencies and funds projects to advocate for and to help initiatives for developmental disabilities. The proposed budget for fiscal year '24 is $2.3 million, mostly from federal funds. At the bottom of the slide, you can see that over 54% of the expenditures go towards other charges. This includes Families Help and Families Resource Centers, Louisiana Citizens for Action Now, and other various initiatives. The average annual spending change over 10 years is 2.8%. And in the funding comparison, here we see the changes from fiscal year '23 to fiscal year '24. The net increase is mainly due to the net decrease is mainly due to the 27th pay period in fiscal year '23. Now we have the Women's Health and Community Health. This is a new agency within LDH. The office was created because of Act 676 in the 22 regular session. The office serves as a resource center for women's health and health-related concerns. The funding recommendation for fiscal year '24 is $3.4 million. Professional services make up 35% of the expenditures, and this is for various contracts to support the office initiatives. Here we have the funding comparison between '23 and '24. The IAT funds are from the Office of Public Health for federal grants to address COVID-19 health disparities, and the increase in funding is to increase 2 classified positions. So that concludes LDH agencies. Do you have any questions for LDH on what we've covered so far? Keep going.
Okay, let's see Representative Edmonds for a question.
Funding for families helping families, families helping families, doesn't it fall under these categories you just went under? Developmentally disabled, isn't that where that falls?
Hi, Amy DeVille, Executive Director of the Louisiana Developmental Disabilities Council. Representative Edmonds, can you repeat your question?
Yeah, do you have any funding that, I know each year, it's not a lot of money, it's a little over $1 million for funding, it's families helping families.
Yes, sir.
Is that included in this year's budget?
The $500,000 decrease is, last year we advocated for that additional $500,000.
Okay.
It was amended in as one-time funds. It is taken out of our budget because it was put in as one-time funds. We would like to see it returned as a
So-
permanent part of the budget.
So last year, we didn't have any money in it, and it was amended, is that what you're saying? I thought we had a little over $1 million in it.
A little over $1 million is what was in after the $500,000 amendment. So the base part of the budget that is always in is $507,517.
So that part is in somewhere, or it's nothing in there? Which one is it?
It's in there. $507,517 is in as part of our state
And a $500,000
general
cut
funds.
that you didn't fund, is that what you're saying?
Correct. That $500,000 was cut, the additional $500,000.
All right, thank you, Mr. Chairman.
Thank you, Representative Edmonds. Representative Cruz for a question.
Thank you, Mr. Chairman. First, on the Office for Citizens with Developmental Disabilities, that's the office that deals with Pinecrest, correct? Someone here that can talk about that? I'm going to read a letter here, short parts of it, and if you could just tell me what the policy is and if this is still in place or whatever. It says, we're writing today to see if our representative senators could assist us in visitation rights for her daughter in Pinecrest. Her rights to receive visits in her living area and our rights to visit her in her living area have been violated for going on 3 years now. It's not an easy thing to have your loved one reside outside of your home, but when visitation is denied, it's even harder. We were allowed to pick her up and bring her home just a couple of weeks ago, but the visitation to her living area is still denied. It's not easy for us to bring her home as we don't have a wheelchair-capable van and some other restraints here in the distance of travel. When we are allowed to visit at Pinecrest, we must be monitored by a queue, whatever that is, the entire time, thus being denied private visitation. At the first visits of this, it was hot and outdoors and very dirty. No restroom facilities for the visitation were arranged. Once an indoor visit was allowed, the queue stayed with us the entire time and was very abnormal. We've been very patient through the COVID-19 restrictive visits, but now we see we're just being denied government-mandated private visits to see our daughter. Could you comment on that and what the policy is and if this is going to continue?
Good afternoon now. Julie Foster Hagan, I'm the Assistant Secretary for the Office for Citizens with Developmental Disabilities. The visitation at Pinecrest continues to change. It's changed a lot throughout COVID. There are federal regulations. In those federal regulations, there's some allowance for any ICF facility to do what they need to be able to keep the residents safe during COVID. And the answer to that is there is no one size fits all, because a lot of it is dependent upon, is there COVID infection of the residents at the time? Are there infections from the staff that may be, coming in and out? And so there's not a one size fits all. They are having to constantly consider those things. We do know that we've heard the same letters as what you read from other family members, and I know that they are at the facility itself actively engaging every day to see how can they begin to reopen those visitation, but do it in a way that's safe for all the residents who live there.
And who is the, medical director who makes these decisions? Who ultimately decides what the policy is?
Tanya Joyner, Deputy Secretary for the Louisiana Department of Health. So our facilities consult with our state health officer, Dr. Cantor. And we're also strictly following what the CDC guidelines are at this time.
Is Dr. Cantor here today?
He is not here today.
Okay. Are you up on the science of what's been going on with COVID in the past 3 years? I mean, where we are today? About transmissibility, about asymptomatic people, the effectiveness of vaccines, any of those things?
I can't speak to the science of it, but
How about the psychology of being away from loved ones?
I can't answer that specific question.
Well, what I'm trying to say, there are a lot of factors in this, and a lot of these things that we were worried about at the beginning have proven not to be factors. They're not dangerous. They're not things that we should give up our normal lives for. And I'm concerned, 3 years now, having a hard time seeing your daughter, that breaks my heart. I can't imagine it. And for what? Every measure we put in place has to be balanced against its effect and what its negatives are. I don't see the positives weighing up here. I don't see the scales balancing whatsoever. This one makes me angry. I couldn't believe it was still going on. I want you to see Dr. Cantor, and I want to get that thing reversed.
We'll take that back and we will follow up with you after this.
And he can come here and defend those decisions if that's still going on. Thank you, Mr.
All
Chairman.
right, thank you.
Thank you, Representative Cruz. Representative Villio for a question.
Thank you, Mr. Chair. What other facilities are like Pinecrest? I'm actually shocked that it's still going on. So what other facilities are like Pinecrest that, do they have the same restrictions, or are the restrictions varied depending upon the facility?
Go ahead.
Yeah, thank you, Representative Villio. Steve Russo, Executive Council, Department of Health. I guess to answer both of y'all's questions, number one, we do have several facilities. We have Villa Feliciana, we have Pinecrest, we have Central, and Elms. That's East Louisiana Mental Hospital System. Really, as the testimony came, there really is not a one-size-fits-all. Of course, Representative Cruz, to answer your question, of course, CMS and I believe the current guidance is to allow visitation, if at all possible, in a private indoor setting. If there are things like an outbreak that is going on at the facility, well, then of course you are bound to protect those other residents from potentially being involved in an outbreak. You're also bound to protect those individuals who are coming into that facility from being exposed to COVID. So those restrictions should be extremely limited at this point. I'm not sure what date is on the email or the correspondence you got, but that is surely something that we will take back both to Dr. Cantor as well as the facility in general to determine what is actually going on, boots on the ground. Okay, it was last week? Yeah, so I will get you an update as to what the status of that facility was COVID-wise last week to see if that could shed some light on it.
I would,
If you don't mind, I also wanted to mention that we've treated this particular thing completely different than anything in the past. We used to keep the people that were sick isolated. Now we're keeping the people well isolated, and there's no explanation for it. Sorry.
I would expect that those situations are extremely limited at this point. Does not sound like it's limited, in my opinion, at Pinecrest. So we would appreciate information in that regard. The one size fits all, the not one size fits all, quite frankly, I think sounds good. But what I think that means is that each facility may be doing its own thing. I don't know if that's what it means, but that's what it sounds like it means. And certainly I would like you to get to the bottom of that. I think we're past the time where parents should be denied visitation of their loved ones, with the exception, of course, of the limited circumstances. If there's a breakout, possibly there is a legitimate reason for doing it for a limited time. But I think we need to get to the bottom of it.
Yeah, absolutely share your concerns, Representative Villio, and yours as well, Representative Cruz. As I testified, my understanding of the science and the current state of affairs was with CMS guidance, the default was to allow visitation unless there was a clinical reason to not allow it. So it should not be a varied policy throughout the facilities that we're over. It should be a very consistent policy.
On that, we agree.
Yes.
Thank you.
Thank you, Representative Villalobos. And Steve, again, you'll be given more than ample opportunity to exercise your new authority. We're just trying a new format here, so it's just kind of a work in progress. We're going to go through the final part of the presentation, and you're more than welcome to come back and make your opening comments.
Yes, absolutely. Thank you, Mr.
Stay there if
Chairman.
you'd like. Did you have a question?
So I'm sorry, so you have a question, the one we just went over? Hang on. Okay.
On the Office of Women's Health here, you briefly mentioned that. I'm just wondering if we could have an explanation of what we spent the $3 million on for year one. Can anybody answer that? I see there are 2 employees, which are totaling, $313,000. And I'm just trying to figure out how that's working out, what's going on right now.
So we have the interagency transfers that we had 2 employees that were transferred from the Office of Public Health. And so when we created the Office of Women's Health, there was also, we had an existing bureau in our office, Bureau of Health Equity and Community Partnerships. So we combined, there was an amendment that was made to that bill on the floor that combined the community partnership section with the Office of Women's Health. And so that section was acquiring 2 TO, and so that is what this funding is going towards for those positions.
The $3 million, what did it go towards?
Well, so we have the positions, there were 5 positions that we're still in year one. So there were 5 positions that were given to the Office of Women's Health, including the Assistant Secretary. So those salaries and benefits went along with those TO. And then we had a transfer of 2 TO from our Office of Public Health to the Office of Women's Health.
Okay, so that was allotted based on 5 employees, but we only have 2 so far. Is that what you're saying?
We were allotted 5 positions for the Office of Women's Health. And then there were 2 positions that we have transferred from our Office of Public Health to the Office of Women's Health and Community Partnerships. That was going to be specifically for that community partnership section. That was already planned, and it was combined when we combined those 2, that bureau and that office in the legislation. Does that make sense?
Somewhat. I mean, I'm familiar with us allotting money, allocating money for positions, but if it's not spent, we didn't have the 5 last year. Where's the money now, I guess? Did it come back? Was it reappropriated?
So we're still in.
I'm looking in 2022, the existing operating budget, there was $3 million.
Fiscal year 20.
So I'm Pam Diaz.
That was fiscal 23 is budget 12/1/22.
Pam Diaz, LDH Undersecretary. So yeah, that's the 23 budget, and we have not, we're in year one, so we've only hired the two employees, so we are
And you
underspent.
expect to fill that by the end of the year?
We're hoping to
Okay.
fill the rest of those by the end of the year, yes, sir.
Correct.
Okay, thank you.
Okay, thank you, Representative Cruz. Please proceed.
All right. Now we're going to get into Medicaid. Medicaid's budget is comprised of 2 budget units, the Medical Vendor Administration and Medical Vendor Payments. Together, they make up the Bureau of Health Service Financing, or Louisiana Medicaid. The Medical Vendor Administration houses the Medicaid staff that determines eligibility, sets rates, looks at claims data, tracks MCO, contract compliance, and investigates Medicaid fraud. The Medical Vendor Payments is the budget unit which makes payments for service, or what most think of Medicaid. The funding recommendation for Medicaid for fiscal year *24 is $18.8 billion. Over 75% of that comes from federal funds. And then on the right, you can see that 89% of the expenditures are for payments to providers. And you can also see there are 966 positions in the medical administration. The funding, here we have the Here we have the historical spending change. The average annual 10-year change is 8.6%. Now we have the funding recommendations for the Medical Vendor Administration. for fiscal year '24 is $669 million. 73% of that is from federal funds and 25% from state general funds. You can see the majority of the expenditures are from interagency transfers and professional services. Here we have the funding comparison. From fiscal year '23 to '24, it's a $74 million increase. This is mainly due to the unwinding of the public health emergency. The funds are being transferred from the medical vendor payments to the medical vendor administration to execute the unwinding efforts. Here we have significant expenditure changes. There's a $12 million increase in personnel services associated with the unwinding. These expenditures have a 50-50 state-federal match rate. Professional services increased by $4.6 million, primarily from non-recurring carryforwards. And then the other charges increased by $29.7 million due to the public health emergency unwinding. There's $25 million for staff augmentation and $10 million for other public health outreach efforts. And this explains the changes that we just went over. The medical vendor payments, the recommended budget from the medical vendor payments is $18.2 billion. About 92% of that goes to private providers. The funding comparison, the change from fiscal year '23 to House Bill 1 is $524 million. And we'll go into detail of the adjustments that make that up in a later slide. The sources of funding, here we have the different sources. Again, the majority of it is federal funds, and then $1.4 billion in statutory dedications, $636 million in self-generated revenues, and $164 million in interagency transfers. Here we have the significant expenditure changes. And the items highlighted in red, we have a slide later on that goes into greater details of that. So the means of financing swap, the net effect of means of financing is going to be $165.7 million more of state general funds. So we're going to go into further detail on that in a minute. The non-recurring ARPA funds is going to have a decrease in federal funds of $223.9 million. The intermediate care facilities, the net effect for the state general fund is $1.7 million increase in state general fund. Rebased nursing home is $31.8 million increase in state general fund. Annualization of the mental health beds is an increase of $25.3 million in state general funds. The public health unwinding is a decrease of $44.6 million. That money is being transferred from medical vendor payments to medical vendor administration. The dental benefit program, which that is a new program, is increasing $19 million. The IAT balance for sister agencies is increasing $6.6 million in state general funds. The clawback payments from CMS is increasing by $10.2 million in state general funds. The increase in MCO payments is going to be, the net effect of that is $610 million. It's having a decrease of state general funds of $68.7 million. Medicare point A and B has an increase in state general fund of $15.6 million, and then the other adjustments is $3.6 million. Here we have the means of financing swap. So like we said, the net effect of the means of financing swap is an increase in state general funds of $165 million. There's several things that go into that. First, the base FMAP is increasing for fiscal year '24, so there'll be more federal funds, $21.8 million in federal funds, and then the state general fund have less state need for general funds. It's a swap there. The enhanced FMAP is being phased out in fiscal year '24. It'll go down to 2.5% in July through September, and then 1.5% October through December, and it'll be completely phased out by January 1st of '24. That is increasing state general fund by $178.9 million. Then replacing the ARPA funds for the Office of Aging Adult Service Waivers will increase the state general funds by $31 million. Again, that's federal funds that have ended. And then the last two is based off of REC projections in the Health Excellence Fund, and then the Louisiana Fund. The projections of going up, so it's a decrease in state general funds. Now we have the public health emergency unwinding. Since the public health emergency was declared in March of 2020, the Medicaid continuous coverage requirement has been in place and has barred Medicaid terminations. Starting April 1st, the state will have 12 months to return to normal eligibility and enrollment operations. Basically, the state has 12 months to review everyone's eligibility that is on the Medicaid's currently determined they're still eligible. This adjustment, again, is moving money from the medical vendor payments to the medical vendor administration. These expenses are actually out of the medical vendor administration. But this slide shows the expenses related to the unwinding efforts. LDH is budgeted that's going to take $89.2 million, and they're estimating 355,000 individuals will no longer qualify for the Medicaid coverage. Here we have the managed care organization MCO adjustment. This is typically the largest adjustment in the state budget. It's intended to capture the changes in rates charged to LDH by the managed care companies. The first line, the enrollment adjustment, is because of the public health unwinding. The enrollment's going down, and it's netted. It's 222 because it's netted. They have a increase in people coming on, but so the net effect of who's going off of the public health emergency net is 222,000. The enrollment, the utilization increase represents the cost trend adjustment for services covered under Healthy Louisiana. The rebate adjustment is an increase in projected rebate collections. And then the transfer of the money to the MVA to be expensed. Here we have the federal medical assistance percentage, the FMAP rate, the history of it. And the part in red is just a visual representation of the savings under the enhanced FMAP. We said that's going away come January of 2024. It's being phased down. And it'll be completely gone by January of 2024.
Could you explain that formula, please? I understood there'd be no math in this presentation.
And then here we have the Medicaid enrollment. This slide shows the Medicaid enrollment trend as it relates to the state population. As of January of 2023, approximately 40% of residents in Louisiana are enrolled in Medicaid. Again, these numbers should go down in 24 because of the unwinding efforts. And that concludes our presentation.
Only person left in the previous slide was just Tanya. So, Steve, you're more than welcome to come up. We'll open it up for questions. And while you're coming up again, I would hope that Dr. Phillips would have something better than to be listening to this hearing. But if she is or if she's not, please convey to her our deep appreciation for her service to the state and all she's done. She will be missed, and we thank her, and also Ruth. Ruth, all the institutional knowledge that goes away with those two individuals. I know you've been there a while as well, but those two individuals were definitely an asset to the state, and they will be missed. But please express our appreciation for their service.
Will do, Mr. Chairman. Thank you very much. I know she is secretary until Thursday or the end of the week, and we're going to keep her as long as we possibly can. So.
Please proceed.
Yeah, thank you. Just let me, before we open up into questions, Mr. Chairman, just kind of brag a little bit on the department. In November of 2021, Team LDH, we released our first business plan under Secretary Phillips. We had certain commitments, and the reason behind the business plan was to give some transparency, give some metrics, and to hold us accountable for how we're spending the public's money. We did have 17 initiatives. We had 42 goals and 258 deliverables. And so with our strong partnerships, working, of course, with y'all as well, we did complete 95% of our deliverables and 88% of our goals. Some of the highlights of which, again, y'all deserve a lot of credit for these, is we did preserve approximately $1.6 billion in hospital funding and then added another $938 million into the system without requiring any extra SGF. So that's a major investment in hospitals and their provision of care. We have a new crisis response system that's going to help in our mental health crisis. It's going to allow, it's live in 7 out of the 10 human service districts. Y'all did provide us with $28.3 million for 224 extra beds for mental and behavioral health services, and y'all also increased for increased access to opioid treatment. So we now have 2 opioid treatment programs, and we have the ability to, and we did distribute 30,000 naloxone kits during last year. We tackled chronic diseases. We increased screening rates amongst 45 and 75-year-olds for colorectal cancer, and we established 16 community-based blood pressure and diabetes prevention programs. We expanded the postpartum coverage to 12 months for maternal health, trying to reduce low-risk and first-time C-section births. We're continuing our efforts to diversify our healthcare workforce. Nursing staffing is a big issue, and also trying to keep other health professionals in our state. We did increase interest among students of color to pursue careers in healthcare, and we placed over 15 medical students in rotations in facilities and healthcare provider shortage areas. Another big item with help from the legislature, we expanded coverage for our dental benefits to those 21 years and above with IDD. So that allowed for an impact for 12,000 residents in Louisiana. We've also, have y'all already heard testimony, we got to create the Office of Women's Health and Community Health. That's being headed up by the Assistant Secretary, Dr. Tori Harris. And we've also developed and went through, as I know the Secretary had testified to, we are doing a 3-year rotating rate review process. So we're currently in year 2, looking at certain rates, and then we'll be bringing those back to the legislature with recommendations about whether certain providers need rate increases, and continue working in collaboration with y'all on those rate increases. Now, our current business plan, we rolled it out. We've got 5 commitments that are covering up 18 initiatives, 45 goals, and 253 deliverables. We're going to continue to advance diversity, partnering with universities and medical schools to increase diversity within the healthcare delivery system. Going to continue working to address chronic diseases. We're going to increase screening and partnerships to prevent obesity, promote healthy food consumption so we can decrease those food deserts that we're seeing in certain areas, and also increase access to healthy food options. We're looking at tackling and developing a sickle cell disease registry and a public information campaign around sickle cell. We're also extending our crisis response services to adolescents, launching awareness more of 988. And then finally, we're going to continue our payment reform efforts. As you know, we've tackled and solved the hospital FMP issue and supplemental payments, and we're now turning our attention to ambulance, physician, and dental. We're going to be solving, hopefully, ambulance and dental with a uniform rate increase through a fee schedule. And then, of course, the big one that we are currently trying to tackle is physician FMP, trying to pivot to a directed payment methodology for physician services. So I appreciate your time, Chairman Zarang, and we will open it up at your pleasure for questions.
Thank you. Appreciate it, Steve, and good luck on your new position.
Thank you. I'm going to need it from all of you, ladies and gentlemen.
Well, we wish you well and appreciate you taking up the challenge, and look forward to working with you. Steve, just a couple things on my end. Last session, H.R. 11, Representative Stagney had a resolution that was looking at rates for inpatient substance abuse. And you mentioned the rate adjustment, the revolving schedule for 3 years, which is great. I mean, we need to do that in many respects. And the thought was that we were going to at least look, maybe those who hadn't had a rate adjustment, it's been the longest since they've had an adjustment, look at those first. It didn't always work out that way. But we're just wondering on substance abuse, and you mentioned fentanyl and others, there was, Louisiana kind of ranks at the bottom for the comparable states in several reports that we've seen, and just wondering what it would take for LDH to look at maybe increasing that so we could address the obvious concerns that we're having, as you know, with substance abuse and helping those who suffer from that condition. I'm just wondering if that's going to be something that y'all looked at. I know, is it going to have to wait until the 3 years till they finally get that point to where they would get the assessment review?
Yeah, sure, Chairman Durang. That is something, of course, you can just pick up the newspaper and read the horrible issues we are having with fentanyl. Definitely going to turn it over to Assistant Secretary to discuss this. Go ahead, Karen. Karen Stubbs. I know your name, Karen.
Hi, Karen Stubbs, Assistant Secretary.
Wait, hang on. There you go. Okay.
Karen Stubbs, Assistant Secretary, Office of Behavioral Health. So that's correct. In the 3-year rate review, year 2 was our licensed mental health professionals. Year 3 is scheduled to be our substance use disorder providers, specifically focusing on those residential levels of care, IOP. We have had several meetings recently with substance use providers urging us to look at that. So we committed to doing a review in the next couple of over the next few weeks and compiling that information. I will say it took us months to do the providers that were submitted in year 2, but we have committed to doing a quick review of the substance use providers and having that information available. There is some discrepancy. Most of our behavioral health providers have not had a rate increase since we moved to managed care in 2012.
Okay, so that's obviously part of it. You think we'll be able to get some idea prior to having to wait the 3 years?
Yes, we committed to trying to do kind of an initial preliminary report and have it middle to end of this month, sorry, was it May or April? In the next couple of weeks, May. I'm hearing May behind us.
Okay. Steve, one of the other questions we had, we looked at recently some of the contracts, and I think I talked to Bethany, but also Dr. Phillips about some of the modules. And one of them, obviously, utilizing NASPO process and how that procedure and process works. And it's primarily looking at the claims processing, which I think is the one that's going to go through. And wondering, there was not an open bid list, or if there is a bid list, how does the NASPO process work when you're looking at trying to award contracts, I guess?
Yeah, so NASPO stands for National Association of State Procurement Officers. Basically, my understanding is that it is a competitive bid and procurement process. It's handled at the national level. So what takes place is several states may be chosen to kind of be the representatives from several states will be the scores. They will open it up to whomever would like to bid on certain things, and then they will handle all the scoring. And then, of course, you will then be placed, if you are a successful proposer or bidder, you will be placed on the NASPO list, and then states that have the authority to utilize NASPO rather than having a in-state RFP that will then be subject, as y'all are well aware, protests down the line that can last quite a lengthy process. All of that is done for you on the front end at the federal level. So now you choose off of that list. There are certain items, I believe, that, for instance, let's take the claims processing module. There are certain things that are included in their bid, for lack of a better word, and then there are certain services and items you can select off of a menu. My term there. And so, of course, for the specifics around what happened for claims processing, we have Mitzi Hoheiser and then, of course, Tara LeBlanc.
So within that process, after the list, as Steve indicated, they pretty much do the initial screening. When you choose a vendor for that process, is there proposals within the NASPO recommended entities, or y'all just simply go through the list and parcel out some work, or how does that work?
Mitzi Hoheiser, Chief Technology Officer for the Louisiana Department of Health. So there are the evaluations and bids that were already submitted that any state can review. And then in our case, we had the vendors come in and give us full-day demonstrations of the products for the key stakeholders, which in this case, for that particular module, was over 50 people.
So 50 entities came in and submitted proposals for that?
I'm sorry, over 50 individuals sat through the demonstrations for the suppliers.
So on the list, I think NASPO, it's 10 or 15, there's a number that they have, but do you open it up to all of them on the list, or you select those who come and submit proposals to you all who are interested?
So for claims and encounters, there were 5. And as Steve mentioned, some of the bidders didn't bid on all of the offerings in that. So some get eliminated just because they don't offer or did not bid on something that the state wants. For instance, one of them didn't bid on federal reporting, so that wasn't something that was available in their offering, and we need federal reporting, therefore we did not consider that vendor.
Okay, but through on the list, do you invite everyone on the list to come, if they would be interested, to come and submit a proposal? Now, I understand that if they don't have items you're looking for, they're eliminated, but do you open it up for all within the NASPO list?
We do not. In this case, we invited 3 of the 5 to demonstrate their product for us.
How do you choose the 3?
Well, one of them didn't meet the requirements that we needed, which was federal reporting. And then in the other case, it was a vendor that we have currently had for 20 years, and so the state at this time decided to look at other offerings.
So you had the person for 20 years, so you decided not to go with them and just look at others?
Well, we decided that in this case, we wanted to see what other vendors have to offer, so we invited the other 3 to demonstrate their products for us.
So there are more than 4. Okay, there's the one that had 20, so you invited 3, but there's more than that. I'm just wondering.
There was one more.
One more. Oh, there's only one more on the NASPO list that met your requirements?
For the claims and encounter processing,
Okay.
yes.
So you don't limit it, you just, those who have or provide the services you're looking for, you invite them off the NASPO list to come in and submit? Because this is a pretty substantial contract, we're talking about $300 million, and just want to make sure, again, competition sparks, it provides some incentive for a better price, and want to make sure that, from the state's perspective, we're allowing for as many who are interested to participate.
I understand, sir. And in this case, with NASPO, the pricing is completely transparent. They had to bid on the pricing when they bid at the national level. So we know the cost of each of the vendors up front.
Okay. All right. Let's see, we do have several questions. Let me see, I want to make sure we go in order here. Let's see, Representative Wheat for a question.
Thank you very much, Mr. Chairman, and Mr. Russo, thank you for being here today. And like the chairman, I just want to make a public comment for Secretary Phillips and Ms. Ruth Johnson for all the hard work they put in on behalf of citizens of Louisiana. And my interaction with those 2 individuals as relates to LDH has always been extremely well received. Thank you very much. I think I'm going to reference page 76 in that presentation. So if they can maybe put that back on the screen.
Okay.
So
I already got one.
So my question there is, and help me, they're picking at me a little bit. I think I know what it's about, but that's okay. They wanted me to ask a question about carbon sequestration in this.
We're going to get to that in a bit.
And I'm not going there, all right? So I'm just trying to digest this particular slide, though, and make sure I understand exactly what we're doing here. And so I think there's like $89 million, a little less than $100 million that we're shifting from one spot to another, maybe or maybe not, I'm not sure about that. Is there new ask in this for something additional that we're going to be doing here, and how much of that may be state initiative versus federally mandated directives?
Yeah, let me just hit the high notes on this, and then I'm going to turn it over to Tara LeBlanc, our Executive Medicaid Director. This is something that, of course, we've been planning for quite some time, the Medicaid unwind. CMS was coupling it with the public health emergency ending, and then that's when the unwind was going to start. In December, they uncoupled the public health emergency with the unwind, and then, of course, said that we needed to start to unwind. There's certain reporting requirements that we're going to have to meet with CMS monthly once we start the unwind process. They are also requiring us to do it over 14 months. If you don't do it, I guess, properly or in a way that's in accordance with CMS guidelines, you run the risk of potentially having fines up to $100,000 a day. You could also have FMAP reductions. I think it maximizes out at 1%. So that is why you're seeing money being moved from MVP into MVA to allow us to do the outreach that is necessary to get the message out, also to do system changes that is going to be necessary for once we start this unwind. But I'm going to let Tara get into the specifics about the dates of when things starting and how the money is going to be utilized.
Hi, good afternoon. Tara LeBlanc, Medicaid Director. For Louisiana, we will start our first redetermination process. Will be run the last weekend of April, and the first letters will be dated May 1st, and that's for the group that is in the month of June. And our first disenrollments will be July 1st for that group. We basically have to take the population over the next 12 months and redetermine their eligibility with from the unwind process. It's the 12-month process that we go through. So each Medicaid member and household will be redetermined for eligibility at some point between over the next 12 months. So our first disenrollments will be July 1st, based on the unwind redetermination.
So the money that we're talking about, little less than 100 million, is actually being spent on the process that it takes for you to get them off the rolls, or is it an outreach where we letting people know out there that they're fixing to be taken off? And if so, can we justify $100 million to let folks know that they've been on the program, but yet now it's time for them to get off?
Well, a portion of the money, total dollars, 15.1 million, is for system changes required. So our eligibility and determination system had to be updated with the latest guidance that CMS sent in January based off the Consolidated Appropriations Act. So we are spending some money to update the system requirements to be able to process the way that CMS's guidance requires, so we eliminate the penalties. Then there is some staff augmentation. We're also trying in attempts to contract with a staff augmentation contract to increase our call center, as well as do some outreach and return mail processes. There are two things that the Consolidated Appropriations Act requires that CMS issued in late January, state health official letter that tells states the guidelines to do it. The first one is that we must attempt to do outreach to members to get their contact information updated before we do redetermination. So that's number one, compliance, and they defined it as a good faith effort, whatever good faith effort means, but we have to do an effort just to make sure that we don't jeopardize the enhanced FMAP that we will be receiving. So that's the first new requirement. The second requirement is that any returned mail that we receive for this unwind process, if it does not have an updated address, we have to reach out to that member in at least two modalities, meaning the letter being one. The second modality could be a text, a phone call, or an email. So that is the reason, one, for the staff augmentation contract is we're increasing our call center because we know the call center will be inundated with calls. And two is the return mail piece, is that we need additional staff to be able to reach out to those members if we have to call them, process that mail, make sure that we have it updated in the system correctly, because our reporting to CMS requires to know how many one of the pieces is about the return mail and how many did you outreach each month and so forth.
And so I think in my previous question, I was trying to ascertain and I think you answered it there, but I just want to be sure. So some of this is federally mandated that we have to do certain things in order to get people off the roll. And so the compliance that you're doing and the outreach is to meet those expectations of what the federal mandates are.
Yes, sir, that's exactly it. Everything that we're doing in this outreach and updating the system and all of that is required by either the Consolidated Appropriations Act or CMS's guidance of implementation, interpretation of that Consolidated Appropriations Act.
Yeah, and Representative Wheat, some of the reporting requirements, for instance, we're going to have to do monthly with CMS. I know one of the metrics they're going to be looking at is how many people we've rolled or removed from the rolls just for like ministerial reasons, like for unreturned mail or unreturned email. I've got a feeling that probably after the first quarter of us responding with those reports, we're probably going to end up getting some more guidance from CMS. I think what's also important for us all to remember is right now we've got a little north of 2 million folks that are on Medicaid. These folks haven't heard from us now for 3 years. So this is going to be kind of our first major outreach, and we have to reach out to all 2 million of them. I know we've estimated we're going to roll off around between 280 and 350,000 folks. I think the budget was built on 350,000 being rolled off, but we do have to outreach to 2 million of those. And we want to make sure, of course, that the people who don't meet the criteria, yes, we need to remove those folks from the rolls. However, we also want to make sure that the people who do meet the criteria, they understand that they need to open up this letter, they need to update their information so that they don't lose coverage, don't lose continuity of care, don't lose preventative care, because then we're going to get back to the situation of those folks ending up presenting to the ER. And now you're going to have, potentially they will come back on to Medicaid, but you'll have higher cost services in an ED rather than continuing their care through the managed care companies.
When do we expect the end of the end process, when we're back to ground zero before we started?
12 months, CMS is allowing states 12 months to initiate the renewals, and we allow members 60 days to respond. So it's a 14-month process for us.
14 months.
Yeah, then the only other wild card that's in there that I've been telling everybody with my lawyer hat on is of course, when you deny somebody and before you remove them from the rolls, you have to give them a right to appeal. So if they take an appeal, then they continue to receive those services until the decision is made. So that's a little bit of a wild card.
Just when you just look at the chart, it just seemed like a lot of money to take and write, get back to where we were, but I guess the mandates in some instances. And look, I was just trying to figure out ways to save money, so if we need some to monitor CO2 on Lake Marpole, that we have that ability to find money somewhere, right? So I satisfied them, right? Okay.
Representative Wheat, I do want to also bring out that Louisiana is one of 14 states that CMS said our plan and our system is in compliance. Again, we're just one of the 14 that CMS has already publicly stated that we're in compliance with our plan of outreach and our system and our procedural changes to go through this process.
Thank you very much.
And for all intents and purposes, the process has begun, right? And we have a year?
We have a year. We will actually start the redetermination process the end of April, the last weekend. What did occur this past weekend is that because the continuous coverage ended March 31st, our system is back to pre-COVID normal operating, meaning that if a new individual comes on, we would process them in throughout the without COVID rules.
Thank you very much. Next question, Representative Bacala.
Thank you. I want to talk about enrollment, but I do want to follow up a little bit on your conversation with the chair about and specifically when y'all were talking about claims encounter process. Is that related to the Medicaid modernization relative to medical vendor payment or reimbursement and streamlining and modernizing that process?
Yes,
Yes,
that's
sir.
part of the modularity deal. Right, exactly.
All right, so that looks like, we were talking about this in '21, so are we getting close?
That's a relative term, Representative Bacala. I know states and Mitzi can, of course, give us some specifics, but I know it's a long process to get these modules implemented. It's a, I believe, Mitzi, correct me, 3 to 5 year process to maybe get one of these modules?
So the expectation is that we will get through the participating addendum with the selected vendor this year, hopefully early fall, and they predict 2 to 3 years to implement this particular module. So, and this is the big kahuna, as you might say.
Would that be 3 years with a 2-year extension?
With NASPA, we're not bound by the 3+2 rules, Representative Bacala. But anyway, this is the significant portion of the mainframe replacement.
Okay, well, I'll get on to expansion, and congratulations, Mr. Russo, and I will agree that Courtney Phillips and Ruth were great to work with, and to correct the record, you're really a recycled interim, correct?
Yes, sir. You know,
Okay.
hey, last guy standing.
All right. Just to kind of synopsize where we are, I think pre-COVID, it looks like from the latest Medicaid reports, it looks like we've grown about 450,000, or 29%. Our Medicaid population has grown by that amount. I do recall right before the COVID protocols that y'all were going to send out 50,000 letters in the month when the letters got pulled back because of COVID. So that would be a 500,000 if you look at the original. Someone said earlier y'all going to be checking everyone. Is that an accurate statement? Because what I had heard earlier was that you were going to only check about 50% of the population, and y'all are going to pre-certify the other 50%.
Well, the requirement is for us to check all eligibility, all members' eligibility. However, during the PHE COVID timeframe, we have been running our renewal job, which checks eligibility. CMS guidelines is that we cannot renew any individual more than often than 12 months unless they have a change in circumstance. So we've been running that renewal job each month throughout the PHE. Some of our members, about half of our members, we can determine their eligibility by using data points from our federal hub and some state data points that we have. And if that was the case, then the member was able to be recertified their eligibility without any human intervention, then we have been advancing those individuals 12 months. So when we go through this process, all members, again, will be redetermined for eligibility. Some will be able to be redetermined by those electronic processes.
And what is the non-electronic process?
Then we mail you a pre-populated renewal document. To me, it's similar to an Medicaid application, but we actually supply the data that we receive from those data points, and the member must either confirm or deny our data points that we received.
Okay, and look, I'm talking about the accuracy of the enrollment process. And I know when we were pre-COVID, we talked at length about where the gaps were. Mm-hmm. And some of the gaps were that there was no way to check, you really weren't checking retirement income, you weren't checking, and look, you can correct me when I get this wrong, retirement income, self-employment income, marital status, were some examples of things that you did not have a database to check against. And maybe there were others. So if we're pinging someone against the database, the federal database, are we still missing investment income, retirement income? Are we missing self-employment income? All those things that we weren't, marital status, all those things that we weren't capturing in our initial efforts?
Representative Bacala, we've been working with you for
10 years.
Probably a couple of years, at least for me, a couple of years, about trying to get other data sources to maybe verify household or unemployment and so forth. And we're underway with that project. We are in the process of we have a contract that we're initiating right now with a vendor that would provide us several different data points, some being of credit bureaus information, some being others that can give us incarceration, not, those type of things. We will actually have our first credit bureau integrated into the eligibility system by the end of this year. And by the end of next year, we will have all the other two and some other data sources. It takes quite a bit of effort to undergo that because it also requires a change to our eligibility process to bring in these new data sources.
So the process, well, let's just say the automatic process where you're tapping into federal databases, you're not going to be checking all those things that we just mentioned?
We're checking everything that's available to us.
And which is what?
Well, not all of them may have self-employment data reported, just
So you're going to miss
like.
those who are self-employed.
Right.
You're going to miss those who have investment income.
No, we actually get some investment income through Acuity and LexisNexis.
What, or if you,
What other ones? We get property assets, we get bank accounts.
Yeah, okay. We also get property assets and bank accounts through the current LexisNexis and Acuity.
marital status.
That one we do not get. Go ahead, that's it. I don't think we received that.
So marital status is coming with the credit bureaus. We did do a pilot on it, and we found that we can get that data through those sources. So as soon as we get those interfaces built, program tested, and
But the point is, if you're pre-certifying people on a database, the federal database that you mentioned, it's really only a half certification if you're not checking those other items as well.
Well, y'all be looking at state too, though, right? I mean,
Right,
we'll
we
be
do get
looking
the
at
wage
state-
data.
Right, we get the wage data from
LWC, right. and
Which,
we-
the wage data does, the wage data includes someone paying somebody. It doesn't include self-employed, it doesn't include retired, it doesn't include investment income, it doesn't include lottery winnings. So that is a very much an incomplete database in regards to earnings. It is a database, but it's an incomplete database.
So we're in the process of implementing the credit bureaus and the lottery actually through our new data broker service.
But you're not doing it for 50% of the population.
It would, once it's implemented, it'll be for the full population.
The first batch, y'all, I'm trying to reconcile. You said we've already certified or 50%, that we don't need to go further, but you have not tapped any of those databases in that pre-certification.
So let's go back to the 50%, and maybe I missed what didn't communicate well. So even the ones that have been electronically satisfied over the last 3 years, they still have to go through a redetermination. It's every 12 months. So they will go through at some point over the next 12 months, they will have to go through another redetermination process.
Okay, let me go back to the original question. Over the next 12 months with the 14-month delay, will you check? Will you be checking 2,036,708 people? Well, that was your projection. 2,023,866 individuals for eligibility.
100% of the population will go through the renewal process.
Will some of the renewal process do a predetermination based on one look at a federal database that does not provide all the data points that are needed?
Yeah, well, it is, and I know we're just talking percentages here, but we're guessing around 47% will be streamlined. Again, it's going to be federal and state databases. I'm not sure when the LDR pilot that we have will be fully online. Don't know whether it will be online for this first month of runs, but we are working diligently to get that online. That will allow us to at least get, I believe, the self-employed folks through that pilot.
Will it check marital status?
LDR will not check marital status, and it will be online in October.
Okay, I think I would rather y'all do a more thorough research before someone's recertified, but we'll let that, it is what it, I won't
Well,
go beyond
we hear
y'all
you
are-
loud and
y'all are-
clear. Let's put it that
y'all are-
way,
Y'all
so.
are making the point that's not really in the plan, to do everything we can do to identify every source of income and marital status and household income and all those things that really determine eligibility. We're doing some, but we're not checking everything. I'm looking on page 68. Medical vendor administration, I guess that, the number that caught my eye on that one is the 86.4% increase.
Well, that's probably bringing in, some of it's bringing in the unwind, right?
Right, yeah.
Yes, some of that is bringing in the unwind money. I believe that's that MVP, the pulling of the approximately 89 million over into MVA. So that's taking up at least some of it, maybe all of it, huh?
I'm also noting, it looks like the federal government's going to unwind the enhanced FMAP quicker than we can unwind or certify the population. That's kind of pretty true.
That is true.
Well, you're going to hear from the federal government that they've been giving you an extra 6.2% for this very reason.
That we should have been putting some of it on the side.
Some states put it all, I believe, on the side.
All right. Well, I'll leave it at this for now. I do think we need to, and look, philosophically, we're getting ready to hit some real problems with the finances of the state in the next few years. I think a lot of us here think we need to start addressing it here today. And here today, meaning, can we continue to afford what we know we can't afford in the future? Should we grow government today if we can't afford it in the next 2 or 3 years? Or should we start addressing the non-sustainability of this budget this year? And what that means in real terms is if sustainability is important, we need to start looking at where we can reduce expenditures this year. And you guys get more than anybody. So, I mean, I think as the discussions go forward, obviously, we're going to have to say, okay, if we need to try to trim, and I'm using the number 200 million this year, that might be too small. But if we need to look at how are we going to start preparing for the future years with this budget that's not sustainable, do we need to try to trim 200 million and put it into, not spend it, we can let it go to surplus, or we move money from recurring expenses to non-recurring. So the conversation that we're having here today goes way beyond just LDH's budget. It goes to the viability of future state budgets. So anyway, I just want to make that point. That's why I think it's extremely important that we start streamlining as much as we can without impacting populations that don't need to be impacted, so that we can prepare ourselves and we're not leaving the next legislature and the next governor in the billion-dollar hole that we who came here in 2016 experienced. I think it's incumbent upon us to start looking at these things very seriously, and it might be painful, but it'd be a lot less painful to gradually start winding down now than it will be to face a billion-dollar budget shortfall in a couple of years. Thank you, Mr. Chairman, Mr. Vice Chair Jack.
Thank you there, Representative Bacala. I look better than both of those old guys. Miss Mitzi, I'm not quite sure I'll butcher your last name. Need you to come back. So let's go back to, you stated earlier when the chairman was asking you about NASPA, I think on the claims part, processing part, you said there were 3 companies that participated in NASPA, but only one was eligible. Would you explain that again?
There were 5 companies that were suppliers for the NASPO for claims and encounter processing.
Okay.
One of them did not bid on all of the business we would need. They didn't bid on federal reporting, so that left 4, and we invited 3 of them to demonstrate their services for us.
Okay, but that was only on the claims part?
Yes.
What about the provider management part?
On the provider management side, there are 8 vendors. I believe we invited 4 of the 8 to demonstrate for us.
And out of those 4, Where are we at?
We have selected one. We have not selected one.
I don't think we're at the point now that we've actually selected and sent over a notice of award to OSP. I mean, that would be the next step, would be to make a notice of award.
Do you have a timeline?
Hold on a second, I'm getting on the fly
I'm
information.
sorry.
Hold on.
I think,
We have notified OSP.
we have notified OSP of our intent of the selected vendor. I think that was just last week or the week before last. It was
Okay.
recent, very recent.
So were they included in our budgeting
Yes.
for an HB1? That,
Yes, sir, that was, we were given funding for that already.
okay. Well, I'm glad to see y'all participating in that
Okay. Thank you.
and moving better than I thought. And I do miss Dr. Phillips as well. Next question, on the wind down, I think you said, Russo, you may have said 189 million?
89 million.
89 million.
Yep, 89.
Okay, I wanted to clarify that because somebody sent me a message. Did he say 189 million?
No,
That's what I don't know, but I'll ask.
89.
So as you begin this process on the Medicaid wind down, and we want to ensure, there's continuity and coverage and make sure that we're not booting people off that are qualified. Are you reaching out to, like in communities in which I live, we have FQHCs who provide most of the services for the Medicaid enrollees. So are you working with them?
Yes, sir. We are, we're actually contracting with several organizations, one of them being the FQHCs, and to help us with that unwind because their population is mainly Medicaid, if not all Medicaid. So we are requesting them to help be navigators through the throughout the state to assist members, get the word out for awareness, as well as if they receive a pre-populated renewal document, if they can help be a navigator to help them complete that and transfer.
So how much is that? Do you have a dollar figure on how much all that is?
Yeah, I mean, we've got, just total dollars, I mean, when you combine advertising and outreach in there, you're looking at around 29.4 for advertising and outreach. And then, of course, you've got also 9.8 in there, which would be like the cost for printing the flyers and then the postage. So looking at that, 29.4, maybe about 39, a little north of 39.
For advertising and posting?
For printing flyers, mailing the postage, general costs, advertising, and outreach.
And our outreach is also contracts, like with the FQHCs and some
Right.
other grassroots organizations.
Like
that
rural
we're trying to-
hospitals. Those-
Okay.
Yeah.
So what's our funding source for that? Is it state general fund or federal dollars?
It's half and half, so it's a 50-50 match. So looking at around 44.6 in total of SGF and then 44.6 in federal. So 89.2 total, but I've got my undersecretary coming up here, so she may correct me.
Nope, he was right. I just wanted to mention that the funding is coming from Medicaid vendor payments, which was the transfer of the 44 million, which the enhanced FMAP released some general fund. So it's a function of the enhanced FMAP.
Okay, so who are going to be, so do you have all those recipients identified? Who's going to do all that? And what are their deliverables?
We have certain folks that we have reached out to that we would like to contract with. I think currently, man, don't hold me, maybe there's 4 contracts that have already been done and submitted to OSP, and I think they've already been approved by OSP. So 4.
And those are all primarily to FQHCs?
The FQHC one has not been approved by OSP. We have submitted, and we're just waiting our approval process. We have negotiated and went back and forth with the statement of work with like the FQHCs, and we're just waiting on state purchasing for approval. And just know, state purchasing has been working really diligently and fast with us. This has been a pretty rushed process.
Yeah.
And one of the things we've also done, kind of a lesson learned through COVID, we've already had in-service training with our contract monitors as to what they need to be looking for on these invoices when they come in monthly, and the supporting documentation. We also have a meeting today with some of the vendors and the proposed vendors to where we're going to get on the same page with them so that there is no miscommunications about what deliverables we expect, what supporting documentation we expect before any payment's going to be made.
Okay. Will we see that before you go ahead and do that? Or will that contracts be, or will you already, we won't see that again then, will we?
I don't believe, no, sir.
Okay. Well, I just want to make sure we're partnering with those that are going to do the best job.
Yes, sir.
Maximizing our touch points with the people that touch those folks. Right, exactly.
Okay. And last week after Senate Finance, in the paper, all those numbers got out, and I had a lot of people calling and asking a lot of questions. And as you can imagine, when you tell somebody $9 million for postage, it's overwhelming.
I can understand.
$29 million for advertising. There's a lot of questions asked by the public when they hear that and read that.
Yeah, and my response to the public is there are 2 million folks that are out there. Granted, as Representative Bacala pointed out, there's 47% or so that are streamlined, 53% that are going through that regular process. But the stick on the other side from CMS to get this right is the potential for 1% FMAP withhold, $100,000 a day penalties, and then potentially them saying until you get your stuff right and do it the way that we want you to do it, you can't take people off the rolls. So that's the stick on the other side.
Okay, one more question, I'll close. Of that money, is this a 2-year process? Is this a 1-year process? I mean, are we budgeting this for 2 years, 1 year? How much are we budgeting this year and how much are we budgeting next year?
So it is a 12-month process starting around now, with 14 months to do the work. So the outreach and stuff, we have to make sure that our population is basically divided by 12 over the next 12 months. So each month they'll have a 12th of the members in there, basically. So we need to continue that outreach effort about updating their contact information to satisfy CMS's requirement up for the next 12 months. This is not a push this month or next month or anything like that. It's for the next 12 months, starting now.
Is it 89 million this year and 89 million again next year?
No, it's going to be 80, Pam, correct me if I'm wrong, but it's 89 million starting July 1, and we should be done before the end of this upcoming fiscal year.
Okay.
So it's a 1 fiscal year deal.
Okay.
We also have 106 million in '23. So there's 106 in '23 and 89 in '24.
So there will be additional costs.
There was additional cost this year.
In this current year.
But
Okay.
89
For '24.
for 24 for the year we're talking about.
Correct.
So you got the 89 covered for this year?
Yeah.
Yes.
Yes.
Sure you do. Thank you. That's all I have.
No, thank you, Acting Chair.
Representative Cruz?
Ready? Mr. Russo, congratulations on being in this position. I got to admit, I like challenges, but I think yours is going to be bigger than you think, and we're going to hold you to it. So first, I wanted to talk about something that y'all do that I like, that the legislature made you do, but I love it, and that's the report card. I wonder if you're familiar already with the 2022 health report card for the state of Louisiana.
I am not intimately familiar with it, but you can guarantee that as part of my challenge, I will get familiar with it.
All right, well, I'm going to read you just a few things from it. First of all, there's a slide early on that talks about how many people are covered by insurance. And I'm going to get to this point later, but I'm going to posit that that has nothing to do with the health of Louisiana, because we have more people covered now than ever, and yet our health indicators are no better. Matter of fact, from that last graph, before you came to the table, I think 63% of all Louisiana is on Medicaid, Medicare. Did I get that right?
It's 40.
Yeah, what was the little graph underneath it?
47%.
There was a bar of 47, and there was a bar with 17. Expanded, right. So effectively, right now, 63% are on insurance, right? On Medicare.
It's only
Am I reading that chart wrong? Regardless, anyway, we know a majority of the people in Louisiana are not on the private insurance. I think we can admit to that. When I look at the indicators, you talked a lot about metrics here, about all these goals and deliverables that you have for LDH. I heard preserve funding, injected more, crisis response system, access to treatment, more screening, prevention, all these things. But I didn't see anything mentioned as, here's our goal for obesity. Here's our goal for blood pressure. Here's our goal for diabetes. We're going to reduce this much. We're going to improve this, something else. Infant mortality by this much. Low birth weight by this. Those are the kind of deliverables I want to see. We're talking now about a budget that's 41% for your department. 41%. And we have a responsibility to taxpayers to make sure this money is used wisely. Not only that, we have a responsibility to the rest of the nation. We're a recipient state. We receive more money as part of our state budget from the federal government, from all the other states, than all but 2 other states. I think we owe it to them to do the best we can with the money we get to improve our health outcomes. Not to say we spent more on this, and this is what were the outcomes for these things. So let's go through just a few of them. Obesity. Scroll this up here big for us. We rank, I'll do a couple things. 47th in percentage of obese adults, 47th of the states out of 50. 46th in percentage of adults with diabetes, 42nd in diagnosis of cardiovascular diseases. And I look at this over the years, I don't see an improvement. And that, it shocks me, but I don't see any improvement whatsoever. And I feel like with this budget increasing yet again this year, that maybe if we keep this up for 2 more years, we can be 50 in everything. I think we need to look seriously, is the money effective? Are we spending it in a reliable fashion that's actually going to make a difference to people?
Representative Cruz, thank you. Doris Brown, the Assistant Secretary for the Office of Public Health. And you're exactly right as it relates to the data. But I do want to state that part of our business plan deals with our commitment to improving the health across the lifespan of all Louisianians. And we go from obesity to childhood and pregnancy outcomes, as well as cancer. So we have defined specific deliverables that are measurable that we are working on within the Office of Public Health.
And I think those are great, but I want to make sure that those match up to an actual outcome. Not, hey, look, we spent $100 extra. Did the extra $100 do anything? Let me bring up just a few specific things here. I see in the budget, and let me find where it is, something for HIV and AIDS here on the order of $70-some million. $70-some million. And on another slide, you talk about how many in each 100,000 people have HIV. And statewide, that means about 800, a little less than 900 people. That's $90,000 per HIV positive person that we're spending in that program. If you can explain that, I'd love it, because I'm thinking, what if we did this? We took all those low birth weight babies, or the teen pregnancies, we took all those and spent $20,000 on each mother to help her out, instead of $90,000 on 890-some people. It's risk reward, it's a balance. Where's the most effective use of that money?
So we
Yeah, you go first. I'll come back.
So we are working across the board and looking at each of those indicators, and you're absolutely right. 90,000 versus a baby. Medication for each of those areas, of course, exponential as we pay for those costs. And also, as we are expanding our outreach, we're able to address just that, so we can have the impact that you're talking about.
Well, here's what I'm asking for. I'm asking for metrics where you can look back next year and say, hey, we did this Was there any change in the health outcome? I don't care if you spend $200 million on something. If everybody gets better, great. But now I just feel like, well, here's money, here's some more money, here's another program, here's another. What's it doing?
Yeah, and that's surely something, we can track. I mean, I do agree with you, Representative Cruz, that we need to start moving the needle and showing that we're moving the needle. As we pointed out in the business plan, though, the business plan points out how we are going about trying to move that needle. We're increasing community-based blood pressure. We're increasing diabetes prevention programs.
But are those things working?
Well, we're building those programs. We're doing outreach. We're stressing the importance of it. Of course, you can't mandate that people go to these programs. You can stress the importance of it, and you're hoping that as you build this, you stress the importance, you conduct your outreach, how this will improve your quality of life. Then you're hoping that metric, at least relative to other states, will begin to move and will begin to progress.
Well, that's what I want to see. Like I'm looking at teenage pregnancy and birth rates. We're 48th in the nation. 48th. How are we going to reverse that? Just imagine we spent 1/10 the effort we spent on COVID on reversing that, on changing that. 1/10. It'd be incredible the turnaround we could have. We've got to face the fact that what we're doing, what's the definition of insanity? I think everybody's heard the same definition here. Doing the same thing over and over again, expecting different results.
But we do have the results from the business plan.
I was just gonna say, yeah, we're pulling those numbers for you now. I'll be happy to share them with you. Our outcomes from this screening, from our business plan 1, as it relates to our screening for blood pressure, and our chronic disease initiatives, to show you the progress that we have made. But we're gonna continue.
I'm looking forward to that, but I'm looking at the report card from last year, and it compares to some previous years, and there's no improvement. I don't see any category, unless it's some superficial one like real tiny, affects 10 people. I don't see anything that's improved.
Yeah, and I mean, obviously we want to improve. We'd like to be number one, Representative Cruz. I'm sure you'd like to see us number one. So I mean, we both share the same goal.
Let's talk about suicides. 35th among all the nations for suicides per 100,000 people. 35th. We know that isolation is one of those things that affects that. And yet in COVID, we ignored the effect on anything else other than just keep people away from COVID. This is a big deal. People are killing themselves. People are destitute. There's all kinds of factors. I'm not even talking about the economy and the economic factors. I'm talking about depression and issues like that people suffered with. I just read the letter about a family that's not able to see their child in a private manner. It's ridiculous.
Yeah, and I mean, certainly early on in COVID, I think we did recognize as an agency that there are other health effects on individuals other than just getting COVID. The isolation, the not having your family members come by, I think we recognized that at that time. At the time, though, it's sometimes we can forget, but when you go back to March of 2020, April of 2020, I mean, the primary thing was to stop the spread of a disease that was a deadly disease. And so, yes, I mean, that was the primary concern at that time.
Well, here's another one here. Poisoning-related deaths. We had 2,450 people died from poisoning last year. I haven't seen any education programs on it. I don't see any billboards on it. I don't see anything like that. I saw an ad again for COVID the other day, and go in and get your shot and stay alive. Stay alive. That's what the message of the board said. What does that infer? That if you don't, you're going to die. It's ridiculous. Why aren't we focusing on things we actually can do something about? Education programs, there's a multitude of things and resources out there, but I just feel like we're not doing any of them. We're just doing the ones that bring the money. And that's where I'm going to apologize to you in the sense that I know you're in a program and in a framework that incentivizes behavior that doesn't help us out as a state. I know that most of the research has gone from being university funded and state funded in the university to pharma funded within the university, and they get to ghostwrite the article. I know those things are out there, and it's fighting against us. And I don't bemoan the drug companies. They're there to make a profit. But our system is out of whack, and because of that, we're getting no better, no much how much more money we spend. This is a long, lengthy report, and I probably highlighted 100 things in here. And I read it all last night again, and I was like, I can't believe this. Hepatitis C, it shows a graph of people receiving treatment. This is the kind of stuff I think we're not getting anything from. How many people receive treatment? It has a little graph. How many people were cured? It doesn't even mention that. And this is hepatitis B, which can be cured. It does not say anything about that. We want to know what the health improvement is, not how many people were treated. That's only a way to get to the result we want.
Yeah, we will certainly, I know Ms. Joyner said she's going to be getting that data, and Representative Cruz, you certainly have my commitment to circle with you as to try to add some of these metrics that can show you whether the needle is moving or whether it's not moving, and ways to try to get it to move in a positive direction.
I'm looking at opioid epidemic. It's off the charts now. I mean, what are we doing about that? How are we changing the position on that? It's crazy. Statewide, the rate of opioid death in 2021 was 30 per 100,000, an increase of 40% from 2020. Went up 1 year, 40%. That was during COVID, wasn't it? We did not consider any other effects than just what is the CDC, what is the FDA telling us? Let's ignore every other possible factor in this equation, just do what they say. The states, created the federal government. They didn't create us. We have the autonomy to say, hey, thanks for your advice, but this is going to affect us in ways that we can't live with. We have, I would predict, over 1,000 restaurants that are closed permanently in the state because of this. And that's just one of many things.
Well, I'm surely going to agree with you that COVID had negative effects throughout the state on businesses and in people's lives. I'm not going to agree that the department didn't take steps around the opioid crisis and other.
I'm not saying you didn't
public
take
health
steps.
issues,
I'm
'cause we
saying I
definitely
don't
did.
see any results from that.
Fair enough.
Let me just, I'm going to sum up, because I know I could go on this for quite a while, because I just feel like we've been negligent. We've been negligent in this. First of all, I think LDH is spending way too much money for the results we're getting. And not just our money, the Fed's money. I think we can do a whole lot better on that. Number two, I think we should always consider, like Milton Friedman said, at what cost? When we're doing something, what is the cost? It's not like a zero-sum game. There's a balance. There's a balance in every one of these things. For instance, I mentioned the HIV program. Please explain to me how we spend $75 million on 894. When I just read about your nurse-family partnership, I'd like to put a lot of money to that. That sounds like a great program. There's programs around the state I would love to give money to that would have a lot better effect. I think you should pursue goals that most cost-effectively improve the health of our residents. I understand we have challenges here. I love the food. It's fantastic. My wife had celery, onions, and what's my third one? Celery, onions, and we cook it and everything, bell peppers, whatever. And the other day, I love all that stuff. And we had to fight against that, but we also had to educate the people that there are some things they could do that are better than others. I don't think LGA is the judge of medical evidence. I think that was where we really went wrong. That was the filter. Whatever the LDH says, that's the way you guys need to act and what you need to believe and the line you need to tote. We ignored, you know what the vaccine adverse event reporting system is?
Yes, I do.
And you realize more reports were made of injuries since COVID started, since before, I mean, it was in existence 30-some years before that. And you can total all those years together, and there weren't as many as came up during COVID. And we ignored it. Matter of fact, Cantor wouldn't even acknowledge that the thing existed. I mean, they acted like it was nothing, like it was just make-believe. Yet that was something the federal government set up to say, listen, drug manufacturers, we know that this can be a tricky business for you and you're worried about liability. Well, let's have a system here to make sure we check the safety. We ignored it. You're not the arbiter of what good and bad and all is in medicine. You can't ignore the rules and procedures just because they're impediments to your objective. And I'm talking about EUAs, end-user or emergency use authorizations. I asked every single doctor that came in here to bring me one vial or show me a picture of a vial of FDA-approved vaccine in any place in Louisiana. You know, they have the little geolocation on them. No one's ever done it. Why? Never was here. Never was here. It was always the EUA vaccine. It was never the FDA-approved one. But they wouldn't do that. They just want to ignore that because they want to achieve a certain objective. That's not the way you practice medicine, and at least it hadn't been for decades. You got to ensure physicians can practice medicine, not just implement any edicts. I mean, there were several doctors I heard about that were being big advocates for exercise, vitamin D, zinc, ivermectin, whatever, a number of things, and they were just being shut out and shut down. That's not right, and that's not how you practice medicine. I've heard from several people that the U.S. is arguably the best nation in the world when it comes to trauma care. We're great when you're sick, ready to die. Get in there, keep your heart running, whatever, for that short-term stuff. But we're terrible at preventative medicine. We pay twice as much as the next 11 nations for the equivalent health outcomes, twice as much. And a lot of it I know is out of your control, but we have got to do better. This is absolutely ridiculous. When I think of how much money we spend on healthcare and what else needs to be improved in the state, and that we're not getting results for the 41% we're going to be spending, it's disheartening at best. So I just hope you think about those things and look for goals and measures to prove that, hey, this program we're doing is working. Don't just keep the program and say, well, maybe it's not working because it doesn't have enough money. That's our common Louisiana answers. Well, if I had more money, I'd do better or do something. So let's reverse this. Let's make this a healthier state where people can be happy that their government is trying to facilitate their health instead of actively work against it.
We hear you loud and clear. Thank you, Rep.
Appreciate it.
Thank you, Representative Cruz. Representative Romero for a question.
Thank you, Mr. Chairman, and thank you, Mr. Russo, for being here today. And I agree with Representative Cruz. Let's see some results. And so, for the record, I'm a big proponent of that. I want to ask a particular question because I get a call all the time about methadone and why it's not more readily accessible. And I just wonder what the answer is. You know, why do people who have this problem need to stand in line for hours upon hours to get a drug that is going to keep them from taking more drugs?
Karen Stubbs can answer that question.
Yes, sir. Karen Stubbs, Office of Behavioral Health. We agree. Currently, the state has 10 methadone clinics located across the state, roughly one in each of the LDH regions. Actually, as part of our business plan, 2 business plans ago, we released a needs assessment, which is required, demonstrating the need for more access. It clearly demonstrated the need for more access. And so then we followed that with a request for applications in certain hotspot areas, requesting businesses to propose opening those methadone clinics. Because it is so highly regulated by the federal government, Board of Pharmacy, DEA, SAMHSA, the department, you don't see a lot of methadone clinics. What we did in our needs assessment is put 30 and 60-mile radiuses around the 10 current methadone clinics to see which areas of the state were not touched. That resulted in identifying 2 areas of the state that were, my words, essentially a desert. And we released that RFA, received some applications. We have an additional methadone clinic scheduled to open this month. And we are actually in the process of doing an updated needs assessment, because at this point, the needs assessment we did 2 years ago used 2018-19 data. So we're updating it again to see where we can repeat this process and identify another area that doesn't have access to a methadone clinic. Just for awareness, with a methadone clinic, you often appear daily or 5 days a week. And so it needs to be readily accessible because most of the clients there, they're in school, they're working. It allows them to function. It curbs their opioid craving while being able to get the corresponding psychological help and treatment. And so what you see are those people are actually, they're contributing members of society during their journey of recovery. So we agree. We're excited about the one that's about to open, and we're doing the whole process over again to identify another area.
Thank you. I find it intriguing that here in the state we have possibly more medical marijuana facilities than we do methadone or it's just, it doesn't make sense to me. But anyway, and we're not on medical marijuana. The other call that I get is about Adderall, and I think a lot of people get that, and I hate to be specific, but in your opinion, or in y'all's opinion, do you think that that's something that we need to look at as a legislature to limit the amount of Adderall that's being put into our system?
So if we could, I believe we might have some measures that we track in Medicaid. I don't have those handy. It is highly prescribed. I'm not sure if Medicaid's medical director, no. That hasn't come up to my attention recently, but maybe we can follow up
Yeah,
with
and
you.
get you some trends.
Yeah.
Okay, thank you. And my last question, and this is, I guess, for Mr. Rousseau, is I asked back in May, or it was actually right after the start of COVID, for what was the state dollar spent on advertising? And I got a report back after about 2 months that went from May of 20 and for 9 months, and it was about 18 million. Do you today have a number that says from the start of COVID to today, how many taxpayer dollars we spent on advertising just for COVID?
Just for
Both federal
COVID.
and state.
We can definitely get it for you. I don't have it today with me, but that's something we can get. And I promise you, you're not gonna wait 2 months this time to get it.
Right, I just think it's important for the taxpayers to know, what did we actually spend as a
Sure.
state advertising for people to go get a shot that wasn't approved?
Yeah.
And I think it's important that they see how much money we actually, spent. But if you could get that for me, I'd
Sure,
appreciate it.
yes, and you
From
won't
the
wait that
start,
long.
from the start of COVID to today.
Sure, we'll go from 2020 to now.
Thank you. Thank you, Mr. Chairman.
Thank you, Representative Romero. Let's see, Representative Lyons for a question.
Thank you, Mr. Chairman. Hey, Steve. I got a question, and going back to earlier this year, and Tara may want to chime in on this piece. Earlier this year, we got a communication talking about the proposed rulemaking in the NEMT industry as it pertains to the guidelines for the ARP bonus payments for eligible NEMT providers. And I want to know, is that rule making process over yet? I can take your time.
Yeah, Representative Lyons, I do not have the status of that with me, but I will get it hopefully shortly, and if not, I will email it to you tonight.
Okay, so when that process is over, I'm looking at the amount that's estimated in there from state general funds and what have you. So that's going to be monies that we have from expanded FMAP, or is that going to be monies, just particularly ARP monies?
Those are ARPA funds.
ARPA funds, okay. Okay, and we're going to initiate that program starting this year, 23 year, or which year?
Yeah, I think this year, let me get the status and see where we will be on issuing that program to you, to the
Okay.
NEMT providers.
That's fine, that's fine. Whenever you get that information, get it to me.
I have all
appreciate it.
kind of information in 3 binders, but not that.
Not that one. Okay, that's okay. Not a problem. Not a problem at all. That's the only question I have. Thank you, Mr. Chairman.
Thank you.
Thank you, Representative Lyons. Representative Bacala for a question.
Thank you, Mr. Chair. Real quick, and I'm looking at, you may not have it in front of you, but I'm looking at the executive budget as translated into HP 1. Medical vendor payments, when we talk about wind down, you would think that money would wind down, the expenditure, the budget would wind down if we're going to wind down 15% of the population, whatever, 20%. But instead of there being a corresponding wind down in expenditures, the budget shows an increase, both in total budget, federal share, and SGF. The state funds, out of an 18, last year was 17.6 billion. This year you're asking for 18.1 billion, of which $315 million is state funds. Why are we seeing an increase in cost when we're anticipating rolling 20% of the people out of the program?
Representative Bacala, did you say 315 million in SGF? Is that what you
Not in
mentioned?
SGF, in state effort. I think it's 159
Okay.
million in SGF.
Okay. So in the biggest, I guess, adjustment in our budget is the MCO, and that's where you expect to see the reductions for the enrollment decreases. And we actually did have $68 million reduction in the state general fund for that. There were some corresponding increases in the other various means of financing. So the expected enrollment drop is around the 350,000, but there's also going to be continuing increases related to just normal people coming onto Medicaid. So the net decrease is $222,000. I mean, 222,000
You'll have to tell me-
recipients.
You'll have to show, again, I'm looking at medical vendor payments, and I'm looking at total means of finance increasing by $523 million, with
Correct.
the state effort being $315 million, and of that, $159 being state general fund
Correct.
during a wind down.
So what I was trying to explain, the largest adjustment that we normally have in medical vendor payments is the MCO adjustment. And you referenced the reduction in the enrollment. We will have a reduction in enrollment relative to the PHE ending and the unwind, but at that same time, we will have recipients coming on. And so it's in the '24 executive budget, it's only a net decrease of 222,000 recipients, not numbers, but 222,000 recipients after we account for the people that would come on. In addition, we had some other increases unrelated to unwind. We had the nursing home rebase. That was a $125 million increase in '24. We had clawback payments, an increase of $10 million. We had a $47, almost $48 million increase for Medicare Part A and B increases based on dual eligibles numbers increasing, as well as the premiums that we have to pay the federal government. And then we also had a $20 million increase relative to a will adjustment, which is the increases from the other agencies that Medicaid funds.
Okay, I just wonder about, is all, if it really seemed like we ought to be going the other direction. I'm not going to dwell upon this because it's late in the evening. Perhaps we can talk about it at a future meeting.
Sure.
But I think these numbers seem to be a little bit much for me personally, again, when we're talking about trying to have a sustainable budget going forward. So I will leave it at that, but I think it deserves a lot more attention. That in an unwind, I think, look, if you said we have medical inflation's hit 8%, then we ought to be flat. But we're not. We're going the other direction. We're growing, we're shrinking those who we serve and growing the cost, which beyond, I think we're growing the cost beyond medical inflation, considering reducing the population served. So thank you.
But to that point, though, you referenced that some of it is related to people coming on the rolls. On average, in a typical year, I know everything COVID-related, how many people do we add per year on an average basis?
Sure. Daniel Cochran, Medicaid CFO. I think we've averaged about 8,000 to 10,000 new members a month. We've seen some fluctuation of that over the course of COVID. Obviously, early in the pandemic, we were seeing the rolls growing by 20,000, 30,000 members a month. If you look pre-COVID, it was, I think, somewhere in the range of 8,000 to 10,000. And I think probably if you look over the last year, you've seen the rolls grow 6,000, 7,000, 8,000 members a month, something.
So on an annual basis, about 100,000 people were adding to the rolls, is what you're saying?
Yes, sir, roughly, give or take.
Okay. Representative Edmonds for a question.
Thank you, Mr. Chairman. I want to do the same thing everybody else has done. What a privilege and pleasure it's been to work with Dr. Courtney Phillips, both in, as you well know, I've held the Medicaid Oversight Committee meetings with Representative Bacala and others, and of course Ruth and Dr. Phillips, excellent people, love them. We appreciate their service to the state, and we also pray for Courtney and her family and ask the Lord to bless them. They're great people, so I want to start out that way by just giving them, we could spend the rest of the afternoon. That's how I feel about it in every case with them. They're great people. So not to say there's not other wonderful people on staff. It just happens to be they're leaving us and we're not happy about it. So, but anyway. With that said, I wanted to go back to where, and I know we're sort of going through this again and again, but I do think that this is extremely important. And that's where we are in this enrollment adjustment. So I want to go back to page 77. And there's a couple of reports that have been out. I think it's been confusing. And by various sources that they said we plan to spend, one headline said we were going to spend $196 million, which now you guys are talking about way less than that, $89 million. Is there a combination somewhere else of other funds that's not represented here on your guys' page? It's going to take to pay, that's almost $200 million, quite a discrepancy.
Yeah, I don't think there's a discrepancy, Rep. Edmonds is. I think folks are combining last year, like this year's fiscal year and then the upcoming fiscal year. This fiscal year, it's 89 million, and it was around 103.
106 this year.
106 this
So
year.
that 106 is a part of the unwind.
Right, so
Okay,
it's 106 plus.
This is additional, and we're probably not finished at the end of that as well.
Well, hopefully we are. That was a question that was asked. Hopefully we are going to be finished because we need to be finished with the unwind in this upcoming fiscal year.
Yeah, and I think if you guys are estimating on your chart on page 76, if you're estimating 355,364 individuals, it says stated, will no longer qualify for coverage, well, if you're only going to roll off 222,409 on page 77, you're left north of 130,000 that you won't be able to get off in that length of time. It's the only thing that makes sense to me numerically. You see that where I'm looking at numbers on page 76 and 7?
Yeah, definitely on page 76. I do want to just point out again, like we built the budget on 350,000 rolling off. So.
I'm just going by the page 77. It said projected enrollment is decreasing from 1,777,000 then down to 155, which says is a decrease of 222,409. So if you're decreasing 222,409, but your goal is 355, you're still going to be north of 130,000 to get off the rolls.
So that difference is the new enrollment that we were just discussing. So of that maintenance of effort population, the population that stayed on the rolls during the PHE, we think of those folks, about 355,000 of them will disenroll. But again, there's also new enrollment coming into the program every month. So that 355,000 is then being offset by about 120,000 folks of new enrollment to get to the 222.
And you're providing in this budget to make those numbers work.
Yes, sir.
Because I think that's where we're all trying to figure out what the bottom line numbers are.
Yes,
We started before the emergency about somewhere, Mr. Russo, I think we were hovering anywhere from 450 to 505,000, somewhere in there, just ups and downs and around. Now we're going to be north of a consistent million on expansion numbers. I know we're looking at total numbers, but I think that's about what's going to end up being. Is that?
No, I don't think that's right. I know
700,000?
Total, we're at 2 million right now. We were at pre-PHE, we were at about 1.6 million.
That's correct.
If memory serves, I've been around here so long.
It's about 500,000 expansion.
We were running
number.
about 1.2 before, so
Yeah.
you're looking probably about 400,000.
Okay.
I'll tell you, yeah, if just back of the napkin.
All right.
Representative Edmonds, we were right about 460,000 in expansion pre-PHE.
Right.
I think we're right about 770, 780. And we think, as we get through the 14-month unwind process, we'll land around 600,000 or so. So not all the way back down to pre-PHE
Yeah,
levels.
so 150,000 higher than emergency, ballpark. I mean.
Yes, sir.
Yeah.
That's in the ballpark.
I mean, it's a pretty good increase.
Yes, sir.
In looking at what we did last year in trying to take, I'm sorry, I need to ask one more question on this reporting. So if there had never been a COVID, we had a Deloitte contract that was monitoring enrollment, and we added a component in there, trying to add some of the things Representative Bacalai was wanting to add and whatnot, that we made certain that we fixed. That's still in place, and we're still spending money through those guys trying to look at enrollment, are we not using any of those monies as it relates to this additional 90 million that we've got to have? I mean, I think that's a reasonable question to ask about. That's a pretty significant piece of money as well that we were spending with that Deloitte contract.
So Representative Edmonds, throughout the public health emergency, CMS issued iterations of guidance.
Okay.
And each time they issued the new guidance, we were updating the system in preparation for the end of the public health emergency. So we were still doing maintenance on our current system to make sure that, one, we were in compliance, and two, to be ready for when the ending of the Medicaid continuous coverage.
That's fine. I just want to know what the real number is, because there's money we already would have been spending on enrollment. If there had never been a pandemic, we would have already spent millions of dollars in enrollment. And now we're going to spend this more additional now by CMS requirements. We're going to spend that much more. What's the real number?
I don't.
Yeah, what I'm hearing you ask is basically what was our burn rate for our eligibility system?
Which we had significant
pre-COVID.
contract on that.
Right, pre-COVID, and then so
Yep.
now, what are we now adding on because of
Because
the
we're still going to use that money. We're still going to spend that contractual money with Deloitte.
Yeah, right.
And we're still going to use it with enrollment.
Right. Yeah, we can get you that number.
Yeah.
I don't want to back of my hands,
Okay.
so to speak, but we'll get it to you.
Can we get that fairly quick?
Yes, sir. I would
Okay.
think so.
All right. Now moving on, last year we were asked to and have worked on this reimbursement process with hospitals, and going back, and you were talking about memory serve, so I go back memory jaunt here. So when we came on board in 2016, the governor expanded Medicaid. We're trying to get a brand new thing in place. $1 billion worth of uncompensated care. That number is supposed to go down or go away. It dropped down, then it went back up. We're holding $1 billion worth. Now here we are. We've changed the reimbursement process, tried to fix the problems, but we still got uncompensated care of $350 million that's still in this year's budget. Well, why are we still having to spend UCC money?
Well, I'm going to turn that over to Pam. I believe it is correct that we did have a significant decrease in our UCC.
I think it was at about $700 million pre-COVID. I think that's
It was about an $850 million decrease.
Yeah, I believe so.
All right. So what am I wrong on? What's the number in this year's budget for
What's the number in
UCC?
this year's budget for UCC?
Give me just a second.
Three something.
Yeah, I believe it's about 380, but I'll have to get to that number.
380 sounds good. I'll take 380.
Yeah, it's about that.
All right. So why are we spending 380? Why is it not going away? That was a part of all of our discussions of this major overhaul of everything we were doing to get our ducks in a row. And if it's not, then when is it going to go away? I think Mr. Russo, that's
Well, yeah,
a
let
fair
me get
question.
this. Yeah, I mean, yeah, it is a fair question. I mean, let me give you my 60,000-foot view, then I can turn it over to Pam and Daniel. But, I mean, I don't recall us ever testifying that it would totally go away. Obviously, we were going to have a significant reduction when you now start to cover all of these folks in expansion. But, I mean, you're always, I believe, and somebody correct me if I'm wrong, I mean, you're always, because of churn and just because of the eligibility criteria, you're always going to have a certain percentage of your population that is uncovered. And so you're always going to have some UCC out there that is going to need to be.
It just seems high to me.
Yeah, so the number in '22, the budget for UCC was $1 billion, you're right. And in '24, we're bringing it up actually to 396. So there's two components in UCC. There's the uncompensated care, And then there's the delta between Medicaid and Medicare. So I think with the directed payment models that we've implemented is reducing that delta between Medicaid and Medicare, but there still is that uncompensated care out there that the hospitals are tracking, and they're putting on their DISH reports and are expecting to get paid for it at some point.
All right, so I'll rephrase. Can we expect that number to go down some more?
Possibly. I don't know that it's anything that we can do on a directed payment model because it is uncompensated care. It's something that we cannot compensate the hospitals for.
All right, I'll rephrase it again. Can we expect to have $1 million worth of funds as it goes to UCC in the future? Should we be thinking in that direction?
Well, some of that $400 million is some prior year DISH reports. Prior year DISH settlements. So it takes 3 years for a DISH audit to be concluded. So right now we're in 23, so we are paying out. I guess we'll start paying out 20. So there's a lag in those expectations for those DISH expenditures. Again, I don't know how we can affect the uncompensated care piece of that for those hospitals.
I just think if we're looking forward as well of doing budgets, what can we, you hear sustainability. I think that's another big question. And y'all's budget is large. And we have to look at each portion of it to figure out what is sustainable and have decent numbers to have an idea about what we think. If the $400 million is going to stay from here out, I think we need to know it as appropriators to try to. That's a part of the plan we have to figure out. I think it's unfair to us to not have a reasonable number.
Yeah.
Go ahead. We can certainly go back and look at what is in that 396 as far as what's prior year and what's ongoing.
Yeah, you make projections on everything else.
Yeah.
I think we have to have some of those kind of
Yeah.
projections.
And we do have our state facilities are recipients of DISH, and they're not part of the directed payment model, so that those state facilities are a recurring DISH expenditure. So we'll go back and look at that and do some
All right,
projections.
a couple of random questions, and I can be done with this. Any additional fundings for fentanyl care? Because obviously it's become rampant in our country, unfortunately. And I know we have some bills that Representative Villio is going to lead us in. I fully believe that we'll get some policy change, but it's not going to stop, sort of that boots on the ground of what's going to have to be needed for our family members that are going to be in trouble with this. So did you guys, in this budget, did you add any care dollars for fentanyl care?
In this budget, there's no direct increase for substance use disorder treatment. We have seen over the past 6 or so years a huge influx in federal grant funds specific to opioids. The last large grant is SOAR, State Opioid Response, I believe is the R, 3.0. So it was the third in the series. We received that in this past fiscal year, and so it will carry through that. There are 2 years, so it crosses over.
Do you expect that to be reasonable enough to care for our constituents?
Yes, sir. And we reference it several times in our business plan. We're expanding OBOTs, our office-based opioid treatment providers, which are kind of non-traditional care settings. These can be physicians or prescribers. You don't have to go to a substance use specific treatment clinic to receive some of these treatment services. Of course, expansion of methadone clinics, really trying to support the workforce and grow the workforce to start to treat those populations. Just a multi-prong initiative specific to the growth, not just in opioids, but fentanyl specific and the intensity of that.
2 more. One is, are you guys putting any money towards, we know there's a great nursing shortage. We hear it from everywhere we travel over the state. And what can you guys invest in some of our students of the future? Is there any kind of thinking towards how you guys can scholarship, internships, anything that will help so we can get this under control or at least in the right direction?
Yeah, that's a very good question. We're experiencing nursing shortages in our own facilities that we've had to actually go out and get incredibly high nursing staffing contracts. We know that there's nursing shortages also in the private sector. We've been trying internally, working with civil service, trying to get premium pay, trying to do whatever we can to recruit and retain our own nurses within our own system. We are getting with the LNHA and collaborating well with them to potentially get some sort of for nurses who are going through their RN or their LPN courses, could they potentially be automatically qualified to work as CNAs? Also doing some recruitment efforts with high schools, trying to capture certain folks that have an interest in nursing or allied healthcare in general, trying to catch them at that level so that they can be, I guess, ushered into that type of curriculum. So, yeah, because you need to catch these folks early, because I don't think we're looking personally, and I think the data is going to bear it out, that I don't think we're looking at a this year and a next year problem. I mean, I think we're looking at a 5-year problem going. And
So do you guys have some dollars in this budget for those efforts?
I'm not sure there's specific dollars for that. I know we were looking at potentially utilizing some of our ARPA dollars and some of our home and community-based spending plan dollars to maybe try to help us out getting nurses that can potentially go into home-based
It
settings.
just seems like that would be a critical adjustment in budgeting.
Pam is telling me we do, so.
All right, good.
We have about 20 million,
Not enough.
There you go.
we have about $20 million in the request for Elms in our central hospital. And that is taking into account the attrition that we have in the nursing. So we're using some of that attrition to also fund the contract. So that's not the total cost. I think the total cost is around $34 million. But we'll get that for
Well,
you.
yeah, that's for our own facilities. That's where we've seen like the nursing staffing contracts that I was telling you that have basically from last fiscal year to I think this fiscal year, they've basically doubled. So that's why we're working with civil service, trying to get premium pay, some sort of retention bonus, anything possible. But I think what the rep was asking was whether or not we had any money in our budget for like outreach, recruitment, help in potentially the private sector to increase throughput through like nursing.
I think we ought to be doing
No, we
that
do not.
multiple budgets. I think it's a great career for people.
Yeah, so I think
Yeah,
they
I
are
would-
confirming that there's not specific money
Yeah.
in our budget for that, but we are going to continue
Good.
outreaching with the LNHA.
We still in litigation with Mr. Dean?
Yes, sir. He has been, those 7 nursing homes have had their Medicaid certifications revoked and their CONs revoked. We've recently filed a motion for summary judgment to have those licensing appeals dismissed because Mr. Dean would not participate in discovery. So we anticipate a decision on that fairly shortly, and we're pretty confident that we're going to prevail.
We put you guys in position of stronger position last year with legislation. Does it cost you any dollars to have to hire or do anything, or did you absorb it internally?
I know we hired at least one person that is now the head of nursing home emergency preparedness. He is the one that has been getting, for this year at least, for the 22 southern parishes, there was 94 nursing homes that have submitted their emergency preparedness plans. We then got them out to key stakeholders like Parish Office of Emergency Preparedness, Learn, some other valuable stakeholders gave us their feedback on those plans. We have recently then sent our request for amendments out to those nursing homes, and I believe their responses are due probably, if not today, probably coming up this week. So as y'all do know, we've pivoted into not just a review of the plans, but now the department in fact does review and approve or disapprove the plans.
We're glad to get that done.
Yes, sir.
Thank you, sir. Thank you, Mr. Chairman.
Thank you, Representative Edmonds. Representative Cruz for another bite.
This is a different subject altogether. I was wondering if you could tell me a little bit about the Medical Assistance Program's Fraud Detection Unit.
Yes, that's if you're talking about internally with the department, that is still, at least for the next couple of days, under my purview. I'm also executive counsel. I'm also director of legal audit and regulatory compliance. So what that unit does is, at least on the fee-for-service side, they look at provider fraud, and on the provider fraud end, we've got a new system that we just now, I think it's come online, I think it's fully implemented now by, we call it Pondera, that it's much more user-friendly, has much more ability to run data analytics, predictive modeling, in order to ferret out provider fraud. They also now work with the department's internal recipient fraud and abuse unit. Whenever they see something there that it deems necessary for a referral to the Medicaid Fraud Control Unit over at the Attorney General's office, they do make those referrals. We have seen those referrals have an uptick. Also, it is in our business plan to meet certain metrics, certain case openings and closings, both on the provider and the recipient side. On the MCO side, they work with the SIUs, the Special Investigation Units for the MCOs. The MCOs will reach out to them to get approval for prepayment reviews for providers who they believe may potentially maybe overutilizing or something along those lines. So they will reach out with them, and I believe they meet on a very regular basis with those MCO SIU units.
How much did that technology upgrade cost? Approximately.
I want to say, man, don't hold me to this, $700,000, and I think it was all paid for out of the fraud fund.
Okay, and we expect to collect 1.3 million this year?
That's the budget.
Okay. I just read a thing, this, by the way, represents 0.008% of all the medical vendor payments. Not very much. The National Healthcare Anti-Fraud Association estimates that you could collect at least 6.25%. If we did that, that'd be $104.5 million. So what are the incentives? Who gets the money if you recover it? How is that money distributed? Do you have an incentive where you're like, yeah, it really doesn't make the same money, we're not doing it?
Well, I guess it goes along a pretty complex continuum. Of course, there's key TAM actions that, of course, if a individual believes that there's fraud out, they can file what's called a key TAM relator petition. And if the government decides to join in that petition, then that key TAM relator gets a certain percentage. If the government decides not to join in, they get a higher percentage. So that's one mechanism.
So it's up to other people to bring this to your attention?
Well, no, that's one of the avenues.
Okay.
The other avenue is for us to do what's called prepayment review or cost avoidance. So rather than seeing that number you're seeing as for money that's actually recovered, back from folks, what this new system also lets you do is potentially do what's called cost avoidance and not make those payments in the first place. I will get back to you.
My insurance company uses that.
Yeah.
Little joke.
Yeah, I'll make sure that I firm this up with you, Rep. Cruz, because I surely don't want to tell you something that's not correct. But I believe when the MCO SIU units see a particular incidence of overpayment or fraud, if they identify it and they recoup it, they get to keep it because, of course, it hedges their risk.
Why don't you think about that and think about ideas that we could implement or something to make that more, make it a bigger income thing for us. If people are cheating, let's get the money back. Matter of fact, that $105.4 million a year, if we had that level of discovery, the Office of Inspector General, the special agent in charge, thinks that figure is actually probably a drop in the bucket. They think it's much, much higher than this. This is just what they think they can substantiate. So we may be having $200 or $300 million a year, that we're losing through fraud. So I definitely think we ought to look at that and see if we can use that money to backfill some of your
That is
expenses.
high on my radar screen and the departments.
Okay. Thank you, Mr. Chairman.
Thank you, Representative Cruz. Okay, just 7 more questions. Y'all face us. No, that's it. We're done.
All right. Thank you, Mr. Chairman. I
All right.
appreciate it.
Thank
And I
y'all.
appreciate all
And
the
good
work.
luck, Steve.
Thank you.